We have two speakers today. Dr. Balaji Krishnaiah is an associate professor of neurology at the University of Tennessee Health Science Center. He holds multiple academic roles, including vice chair of education, a division chief of vascular neurology, program director, and neuroscience course director. His interests are medical education, research, and patient advocacy. He has been recognized for his innovative teaching methods with over 25 Baker Teacher Recognition Award, HSC, Memphis. He did his medical school at Army Medical College, Rawalpindi, where he's keenly involved in the education throughout his professional career. He has taught his colleagues in medical school and volunteered as a teacher to educate children in underserved areas of Rawalpindi. His interests lie in finding effective ways of educating medical students and residents that involve clear communication of concepts and engage critical thinking. He aims to be a clinician educator as he advances his career. Dr. Krishnaiah and Dr. Arif, thank you for being here. The show is all yours.
Thank you, Ben. And thank you, AN and Dr. Weber, for organizing this. And then we are excited to be here. And we'll finish the lecture probably in the next 45 minutes. And then we'll open up for the Q&A. And we'll try to answer all the questions. And then Dr. Arif will start the lecture.
So I'm going to start off by going through our objectives. What we want from our participants at the end of this lecture is to know what embolic stroke of undetermined sources, know the difference between cryptogenic stroke and ESUS. And then we want all of you to sort of have an idea of all the trials that have been done for ESUS as of now. And finally, being aware of how to work up patients who we suspect have ESUS. So beginning, why do we care about what causes ischemic stroke? The first thing is, depending upon what the cause might be, the in-hospital management for the stroke is different. And then based upon the etiology, your secondary prevention strategies change. And this is really important just because after the person has an index event, what we want most is to prevent them from having another stroke. And then finally, when we're having patient conversations, it's really important for us to know what caused the stroke, just because that will define what we can tell them about what their prognosis is. So the usual etiologies of stroke that we think of are based upon the TOAST criteria. So starting off with large artery atherosclerosis, cardioembolism, and in cardioembolism, we need to see high-risk cardiac features for us to call it like a potential cardioembolic stroke. You have small vessel disease, stroke of other determined etiology in which you can find an etiology, and the last one is stroke of undetermined etiology. Now, when we look at these five main chunks, we can see that undetermined etiology of cryptogenic stroke consists of 30% of the people we see coming in with strokes to the hospital. So when they're discharged, we don't know what caused the stroke for 1/3 of the patients, and that's a really big number. So we think about cryptogenic stroke. Cryptogenic stroke, we call a stroke that when either you have like two or more competing etiologies, you're not sure what caused the stroke, or your evaluation isn't complete. So by that, we mean you haven't done all the investigations for you to definitively say that you couldn't find a cause. Or if everything else has been done and you still don't know, that would be no cause found. So this is quite a big bucket, and it's not very clearly defined. And it's hard for us to sort of parse out what to do with this. So that is why in 2014, the term ESUS was constructed by a consensus group so that we had sort of a clearer definition on which we could sort of work for. Now, ESUS, embolic stroke of undetermined source, you need sort of three main things for you to call that. Number one, it should not be a lacunar stroke. The second being, if you do have carotid atherosclerosis, your stenosis should be less than 50%. And the third thing being, you should not have any high-risk cardioembolic features. The most common one that we think of is like AFib, and then you can call something as ESUS.
So Dr. Arif explained so far why ESUS, what is ESUS, how do you define? It's a clearly defined construct compared to cryptogenic stroke, where anything can be in cryptogenic. So now the question is, now that we define ESUS, why is it important? There's multiple trials that has been published so far showing the prevalence of ESUS, and you can see anywhere between 10% to as high as 40%, depending upon the study that you're seeing, the prevalence of ESUS is really high. And then the second thing is, this is a article in JAMA that's showing when someone has a stroke, what etiology makes them to have highest risk of recurrence. And obviously, if you discharge a patient with embolic stroke of undetermined source, their risk of recurrence is really high. And then the third thing is, and this paper shows that what is the age group that is involving, and you can see very fairly they're like on the younger side of the spectrum. So now it comes to what are the three things? Why are we here today talking about this construct is, we now know that this is one of the most common cause of cryptogenic stroke, and it's predominantly affects the young age, and it has the highest recurrence rate. So that's why like we need to give more importance to ESUS. So earlier, we know the definition of ESUS. How this constructed is this clinical construct, and we think it's mostly caused by thromboembolism. If it's caused by thromboembolism, where is the embolic source are coming from? The embolic source could be various. It can be cardiogenic, it can be arteriogenic, or it could be paradoxical. I want to emphasize again, is cardiogenic, arteriogenic, or paradoxical. Most of the trials has focused so far on cardiogenic, but we will see at the end of the lecture how important it is to focus on arteriogenic or paradoxical. Because now we know most of the emboli are made up of thrombus, the hypothesis was generated, can anticoagulation be the answer for this ESUS? And how do you know the validity of his ESUS? If ESUS construct is real, then how do you validate is the treatment to anticoagulation. If you put the patient on anticoagulation and the risk of stroke is decreased, then you know ESUS construct is real. So that's why we started this topic. Do we need to redefine the ESUS construct? And we saw in the earlier slide, one of the most common cause of thromboembolism is cardiogenic. There's a trial, Crystal AF trial in 2014. It's looked into patients who are discharged with a diagnosis of cryptogenic stroke and they received loop recorder. As you can see, as they monitor for 6 months, 1 year, and almost up to 3 years, patient who had received loop recorder, you're more likely to find AFib compared to patients who are monitored with the follow-up appointments, EKGs, and cardiology visits. And this has given an indication, maybe this construct is true, maybe the ESUS chunk of the patients are having AFib. Now, the question is, now that we know AFib is one of the commonest cause of ESUS, can be validated. So how do you validate?
Yeah, so if someone has AFib when they come to the hospital and they have had a stroke, you put them on anticoagulation just because that has been seen to be effective in preventing another stroke. So the first trial that came in for ESUS, Navigate ESUS, randomized people to either getting aspirin or rivaroxaban 15 milligrams once a day to see if putting people empirically on anticoagulation who have ESUS will prevent them from having recurrent strokes. Now, when they compared the outcomes of the study, you can see both lines approximate each other. There wasn't any added advantage of putting people on rivaroxaban as compared to aspirin. This is one of the tables they had as outcomes. And you can see that the primary efficacy outcome of any recurrent stroke or systemic embolism, there wasn't any difference between the aspirin group or the rivaroxaban group. Though the hemorrhagic stroke risk was significantly more in the anticoagulation group. So this trial did not show us that anticoagulation was effective. Now we move on to the second trial that was done. This was Respect ESUS. This looked at dabigatran versus aspirin. This trial as well failed to show any difference between dabigatran and aspirin. And moving on to the outcomes, you can see that there was a non-significant difference between the primary outcome of recurrent stroke. Though dabigatran did not seem to have caused a lot of hemorrhagic strokes. So these two trials, we saw that putting people empirically on anticoagulation with a diagnosis of ESUS did not give us any beneficial results. So then we moved on to this trial, Atticus, which was published in 2023. The thought process was, if we sort of further divided ESUS patients into them having ESUS plus having any of these risk factors that put them at a higher risk of AFib, whether we might see some beneficial results. So in this trial, they randomized people with ESUS, plus they needed to have one clinical electrographic or echocardiographic risk factor that put them at a high risk of AFib. So they were randomized to either apixaban or aspirin. Again, they did not find any significant difference between the groups. If you look at the primary outcome, they did not find any significant difference, though the major bleeding risk between both groups was the same. Arcadia is the last trial to be published. They also looked at ESUS plus signs of left atrial dysfunction. So left atrial dysfunction was defined as either a P wave terminal force greater than 5,000 microvolt times millisecond, an N-terminal pro-BNP more than 250 picograms per ml, or a left atrial diameter equal to or greater than 3 centimeters.
Can you go back? So I want to emphasize one thing. The reason these three things were picked is there's a paper by Dr. Camel, who is the primary author for Arcadia, and he generated this hypothesis. There's something called atrial cardiopathy, which can be precursor for before the patients can have AFib. And atrial cardiopathy is a left atrial inflammation or left atrial dysfunction that can put the patient on a higher risk of having an embolic stroke. And how do you define atrial cardiopathy is they use this EKG echo criteria and the serum criteria, which shows the left atrial is inflamed.
So when they compared the outcomes for Arcadia, they found that the recurrent stroke risk was exactly the same between the apixaban group and the aspirin group. So it did not show any significant difference. Now moving on to the incidence of AFib that was found in all these 4 trials, you can see that when people are monitored for more than, say, 2 years, about 30% of the people are found to have AFib. And in people who have ESUS, it's about 30% of the ESUS population is also found to have AFib. But still, 70% of these patients do not have AFib. So what's causing the stroke in them is the next question.
So the biggest question we have is, now that we have 4 negative trials showing that anticoagulation is not superior to aspirin for embolic stroke of undetermined source, and everybody's saying then we need to bury a ESUS a construct. It's not real. We need to move on. We shouldn't be giving anticoagulation for this patient. So it feels like we had the similar conversation in 2012, 2013, when we had multiple trials like Synthesis, IMS3, and Proactive trials published and showing mechanical thrombectomy is not beneficial. So then we didn't stop there. So science is not only when you have positive trials, science is also when you have a negative trial, you improve. And this is a slide from Dr. Negura's review article in Stroke, He says just because you have multiple failed thrombectomy trials, it doesn't mean thrombectomy doesn't work. So you need to make sure that you have right target selection of the artery, you have effective devices, you need to make sure the patient has enough salvageable tissue, and the patient's stroke is severe enough where mechanical thrombectomy can potentially show the benefit. Even the previous trials were looking into everything else. So he wants to make sure you have a potential target and then you aim the target. And then you know what happened in 2015 with Mr. Clean, Extend IA, Swift Prime, Rivascat. All those trials has showed that mechanical thrombectomy is beneficial, and that has entirely changed the way that we manage stroke patients. The same would apply for this ESUS trials. It's not yet, we cannot bury this ESUS construct. We need to tailor and make sure that we are properly selecting the patients and anticoagulating them. And that's when it comes to, is it time for a paradigm change? Not yet. The reason for that is, this is a paper by the authors here, including Dr. Camel. And then he says that occult AFib seems to be the infrequent cause of ESUS. As we saw in the 4 trials, it's 1 or 2% incidence of AFib in the Navigator respect ESUS, and the higher to 15 to 20, 30% of patients having AFib. And when they looked into the subgroup analysis of Navigate ESUS, the major contributor of ESUS is non-stenotic plaque ipsilateral to the stroke. And one thing they concluded in the all trials is, if the patient is more than 75 years old, there is evidence to show anticoagulation is beneficial, even if it's empiric. If the patient are less than 60 years old, they should be screened for PFO. So all the trials, we know what is a cryptogenic stroke, and ESUS is a subset of cryptogenic stroke. And you can see ESUS is how we define the ESUS. We were focusing on here, where you have incidence of AFib and you anticoagulate the patient, but still a large core of patients, still where we can call embolic source of undetermined source, but with evaluation, more workup, more thorough workup, other than just the loop recorder, we can weed them out. So what are those things? And this is a paper in JAMA by Dr. Kamala Gaines showing like how much overlap you have between these unexplained sources. And these are on the left end of this graph is the need for the randomized controlled trials where we compare anticoagulant versus antiplatelet. And then these are the places where anticoagulation is not going to work, but unfortunately, most of the trials which has done so far included this end of the spectrum as well. So what can we do to separate this half of it out so that we can try anticoagulation on this end, and then we can see the positive results with empiric anticoagulation? Number 1, let's focus on silent myocardial infarction. So we know with multiple studies in the literature that the MI and stroke can co-occur. And this is the paper which shows the silent myocardial infarction and the risk of subsequent ischemic stroke. And then even in subgroup analysis of Navigate ESUS, we have seen patients with left ventricular dysfunction has high risk of having this embolic stroke. But with the previous trials and the guidelines, if the left ventricular ejection fraction is less than 35% or less than 30%, then we can talk about empiric anticoagulation with the minimal evidence we have so far. But if the patient has preserved EF, but they have left ventricular dysfunction, we cannot blow it off. If the EF is less than 40%, we cannot blow that off as well. So now we need to look into those patients closer to see whether we can select a study where patient has left ventricular dysfunction with preserved EF. Can they benefit from anticoagulation compared to aspirin? That's for the future studies. And there's more to stroke etiology than those criteria, as you can see in this slide. And then going on to the next one, which is one of the major things that we need to consider, is large artery atherosclerosis without luminal stenosis. So we know that if the patient has non-stenotic carotid, the cumulative risk of stroke is higher with these 2 studies. I can show you a graph here. This is a study which showing what is the risk of stroke as your stenosis increases. We know if it's more than 50%, the risk of stroke is higher. So we have done studies with NASET and everything to show what is our CREST studies to compare medical management is beneficial compared to surgical management. If the percentage of stenosis is less than 50%, we kind of blow it off saying that's not what causing the stroke. Even though it's less than 50%, still you can see the risk of stroke is higher. And it's followed by, what if I look into plaque morphology by doing a cerebral angiogram? Even if it's less than 50%, if you have like irregular plaque rupture or other features, your risk of stroke is significantly higher. But how many times have we considered patients to get DSA if they're less than 50% stenosis? Then we need to keep that in mind as well. So going forward, a non-stenotic cervical carotid plaque is more common ipsilateral to the infarction, particularly in the patient with ESUS, but not in patient with AF. We have seen this common in all the ESUS trials, and mostly it is published in a subgroup analysis of Navigate ESUS. So what do you mean by that? And you can see the patient is having substenotic carotid, and they will measure this as less than 50% stenosis, but it could be the cause of this stroke involving the border zone areas. But this patient might be coded as embolic stroke of undetermined source, and they may get other rest of the workup and get a loop recorder. Anticoagulation is not going to work for them because the pathology is in the carotid, not in the central source. And what can we do? So they define a new concept called symptomatic non-stenotic carotid. What is a SYNC? SYNC is a non-stenotic carotid lesion, which is less than 50%, but they have high risk features. When we say high risk features, what are those? You have an irregular wall protruding into the lumen. You have mixed density plaque. The plaque is ruptured, and you have a lipid-rich necrotic core. Our patient has intraplaque hemorrhage. All these features you can evaluate either using carotid ultrasound or MRI or even in the CT angiogram. And you can see in a different way, like how every signal will look like, how the calcification will look like, how a fibrous cap will look like, and then how the necrotic core look like. And this is a paper by Dr. Ziegler explaining what is the stroke risk for non-stenotic plaque. You can see of all ischemic stroke, we can say 20% are ESUS patients. But if you look for this 20%, there's more likely they will have non-stenotic carotid compared to patients with other etiologies. So that's why it's extremely important for us to know, even with non-stenotic, to look for high risk plaque features to see whether this could be beneficial. And this is a plaque RATS classification, where they give the score of RATS 1 to a normal wall, all the way to RATS 4, where you can look for ulcerated plaque, intraplaque hemorrhage, or with a thrombus sitting on it. There are three things which is extremely important for us. Those three things are intraplaque hemorrhage, fibrous cap rupture, or an overlying thrombus. When you have this, even though it's a non-stenotic carotid, but that could be symptomatic and causing the stroke. So there is an ongoing trial where they're looking for, it's called CAPIAS trial, to see if the patient has ipsilateral non-stenotic carotid stenosis to their stroke. Can that be, what is the risk of recurrence? And that's what they're looking at in a CAPIAS study, which is an ongoing trial. And we saw silent MI, we saw large artery atherosclerosis with a luminal stenosis. Now we see the occult cancer. You can see in this paper, the diagnosis of cancer is preceded by arterial thromboembolic events. As you can see, even the patients are diagnosed here, they have higher risk of having malignancy even before the diagnosis of cancer happens. And when do we cannot just go ahead and screen every single patient for malignancy. And this is a paper published in Green Journal, which they call it 3 territory sign. What's a three territory sign is if your patient has MRI or DWI restriction in more than 3 vascular territories, is more likely from malignancy compared to AFib. So that's why it's important for us to get some history from the patient, like if they have any weight loss, any symptoms that could make us to think it could be secondary to malignancy, which can lead to further investigation about to look for any indolent malignancies that we are missing. Even though this can be called as embolic stroke of undetermined source, but knowing that occult cancer can cause it will help us to do the proper workup. Then moving on to PFO. There are multiple studies in the past has shown the PFO closure is not beneficial, but with the recent evidence with 4 major randomized controlled trials, we know the risk of PFO, the benefits of closing PFO is much more compared to just medical management. So how do we do that? Is one thing is ROPE score. What is a ROPE score? You can see on the right end of the slide. What is a ROPE score tells us is whether the stroke is PFO related or not. If a patient has a higher ROPE score, there's more likely it's related to stroke. What does a higher ROPE score mean? If a patients are younger and they have no risk factors with a cortical infarct, it's more likely from PFO. If you have a low ROPE score, like older patient with multiple risk factors, PFO is unlikely. So that's why the evidence has so far shown if your ROPE score is higher, sometimes we don't in this ROPE scores like ABCD2 score. You can have a low ABCD2 score, but if you have an ipsilateral symptomatic carotid stenosis, then it kind of changes your management. So that's why it's important to know what is the echocardiographic features too. That's what Pascal's calcification came in to look for high risk PFO features, including atrial septal aneurysm. And this combining both ROPE score and Pascal score, you can divide this patient into unlikely, possible, or probable. When it is probable that PFO is the cause, when you have high ROPE score and a high risk PFO features, the patient will benefit from PFO closure compared to just medical management. That's why it's extremely important for us to know the etiology of the stroke. Even though it's embolic stroke of undetermined source, it can be from AFib, it can be from non-stenotic ipsilateral carotid plaque, it can be from occult malignancy, it can be from PFO. That's why it's extremely important for us to have thorough workup. Even though when the ESUS construct was defined, we said it is the validity of ESUS can be only defined by response to anticoagulation, but we don't know just anticoagulation with one medication is sufficient enough, or as the COMPASS trial showed, patients when they combine with rivaroxaban plus aspirin, they have significant benefit compared to rivaroxaban alone. Maybe the future trials could head towards once we take other cause of ESUS out, if it's from AFib or atrial cardiopathy, then we can combine anticoagulation with aspirin and compare to anticoagulation or aspirin alone to see whether that could be beneficial. Those are the future directions that we head into. So the take-home points from today are ESUS is heterogeneous, even though AFib could be a part of, could be a commonest cause of, one of the commonest cause of ESUS, but that is not the only cause of ESUS. There are other things that we need to consider, which is including symptomatic non-stenotic carotid. If it's less than 50%, instead of blowing it off, we need to make sure, are there any high-risk carotid plaque features, including intraplaque hemorrhage, fibrous cap rupture, or patients having any overlying thrombus, then that could be the etiology that we are defining. And in those scenarios, we can do further workup with angiogram to look for irregularity or ultrasound or MRI with vessel wall imaging. There's multiple studies as published on black blood imaging on carotid features. And we need to ensure that the diagnostic and treatment plan for ESUS is personalized and customized to individual needs. For example, if a young patient has an embolic stroke with no risk factors, we need to obtain a trans-esophageal echocardiogram to make sure the patient does not have a PFO. We know with multiple studies in the past that TEE is more sensitive and specific to find a PFO compared to TTE. And then if the patient is older, has a 3 territory sign, we need to look for malignancy, or as we mentioned before, looking for symptomatic non-stenotic carotid. So until we get to customize or tailor the patient needs and identify the right patient population, and then when we can consider empiric anticoagulation for them and do a study on them. Until then, we cannot just eliminate the ESUS construct. And maybe we can take this time to redefine the ESUS construct rather than completely eliminating the hypothesis. That is all from our end, and we can take questions now.
Thank you very much. That was great for me because I've been out of the stroke world for about a decade since residency. So all of that seemed novel. So some of my questions may be even too basic for a resident, but if you have a patient with ESUS who you find one of these things on, like occult malignancy or complicated plaque that's non-stenotic, would you still call them ESUS? Or do you then change your documentation to call them what you think is the most likely etiology?
So we cannot call them ESUS anymore. So that's why this paper from Dr. Albers and it recently mentioned, if you identify PFO, we need to eliminate them from ESUS subset and call PFO related stroke. And if the patient has non-stenotic ulcerative plaque, then we need to eliminate them from ESUS and say those are strokes from carotid rupture. This is not undetermined source anymore because we determined the source.
Mhm.
And that's why it's extremely important for us to, even though we did a fantastic job in the past with the authors constructing this ESUS, but we need to make sure that construct still is valid, but we need to make sure that other patient doesn't end up there.
And all attendees, feel free to pop up questions in the Q&A. We'll keep an eye on those as well. Looks like the first one rolled through. If there's no 3 territory sign and the loop recorder is negative, would you still consider malignancy screening?
Yeah, so if a patient is older and if they don't have any other risk factors, like there's no carotid stenosis, and then if they have embolic stroke, and if they have any underlying signs of malignancy, since in weight loss, unexplained weight loss, then yes, I would consider doing a malignancy screen for them.
And how extensive of a screen do you do in your typical population?
Yes.
Say
So
they did have the three vessel or the
Yeah.
3 different vascular distribution sign.
So even though we want to get the PET scan, we don't have an option to get a PET scan in the hospital. So we would start with a CT scan of chest, abdomen, and pelvis, and then to see whether we see any signs of malignancy underneath. If not, then we can go further. But the initial is just a CT scan.
In folks with those complicated features of the non-stenotic carotids, would you still move forward with, is there a minimum occlusion level that would make you push for an endodorectomy in those cases if you think it was symptomatic and caused a stroke?
Yeah, so there's no minimal level, because when we use the minimal level, that's when we start eliminating them. So in the previous studies, when we showed more than 50%, we call where surgical management would be beneficial. Then we started eliminating the less than 50%. The patient may have less than 30% stenosis, still that'll be irregular. So when we see irregular plaque in CTA, that will help, then that will make us to do more workup, maybe get a carotid ultrasound to look into locally to see what's going on. Because it's more like volcano, it's ruptured, it's already gone, and you just see the remnant of it. And then by doing a carotid ultrasound, maybe you can look for the fibrous cap rupture. When you see a fibrous cap rupture, that will make you suspect that is the etiology. That could be the more likely etiology than an AFib.
But if you see that, say you see the 30% stenosis with a fibrous cap rupture and an active thrombus even, would that change what you're doing for the patient?
Yes, great question. So we have a anecdotal evidence or like systemic reviews that has shown that surgical management would be beneficial compared to medical management for this complicated plaques. But we don't have a randomized controlled trial evidence. So that's the once we prove that this is what causing the stroke, then the future is to compare surgical versus medical management. And in our practice, when we see this complicated plaque rupture, and when they do the DSA, I have seen the endovascular physicians calling me, this needs to be cleaned up before he goes out of the hospital because it looks nasty. But in the CT angiogram, it could be completely, it looks like clean, it could be substenotic. But when you go closer, when you take a closer look at it, it will be something that they don't want to send the patient because it's an active brewing source for further clot formation.
What is the secondary prevention if you find the sink? Would you consider dual antiplatelet therapy for them? If yes, how long?
For now, we consider dual antiplatelet therapy at least for 90 days. If there isn't any evidence to show 90 days, because all the large arterial atherosclerosis that we have has shown more than 50% or more than 70% for, as a matter of fact, to show DAPT works. But I would consider DAPT or longer term DAPT for them with a closer follow-up.
How common do you think early vasculitis could be presenting as part of the ESUS category, and what investigations do you do in your ESUS patients to look into that side of things?
It's a great question. So when we know the prevalence of vasculitis, the age group that is involved, and then the vascular territories that it can involve. So most of the vasculitis involves the anterior circulation or the posterior circulation, and then you can have punctate subcortical stroke with vasculitis, not less likely a wedge-shaped infarct, multiple cortical strokes with vasculitis. When I see patient with subcortical punctate strokes having a headache and then CTA shows irregularities, then I would consider vasculitis workup even in the first admission. And if the patient having irregular vessels in the CTA, but they don't have any risk factors to support that, then it would make me to think what is causing their focal luminal stenosis. It's not atherosclerotic. Then I would consider DSA or brain biopsy depending upon the patient that I'm dealing with.
Rolling in. How long do you usually monitor your patients in ESUS for cardiac arrhythmias? Filter typically, or loop recorder more commonly?
Yeah, so our practice is to get loop recorder because with the studies that we have so far, including ACID trial and other trials, that the longer you monitor, the more likely that you'll find AFib. And one of the good evidence is from 2014 from Crystal AF trial, where you can see 6 months and 12 months and 36 months. The longer you monitor, the more likely you're going to find this AFib. And then the recent trial, stroke AF trial, also showed the longer you monitor, the more likely you find. And once I place the loop recorder, I'll continue to monitor them until the battery dies.
In the malignancy-related stroke, are these typically more arterial thrombus or venous thrombosis with paradoxical embolism?
Great question. So we know that malignancy-related strokes more likely can cause venous thromboembolism. And if a patient has a history of DVT, anything in the past, and they have arterial thrombus now, that is one of the reasons for me to consider malignancy workup in a patient with ESUS. So as I mentioned before, all the PFO trials has shown that the benefits of the most benefit is patients who has less than 60 years. Then the question is, can we not screen patients with PFO if they're older? So if I have a 70-year-old and they have no risk factors whatsoever, and they have embolic stroke, and they have a history of unprovoked DVT, then I may consider getting a TE for them to see why are you having embolic stroke, even though I'm going to monitor your heart for AFib. That's what going back to the first point of the take home today, ESUS is heterogeneous. You can have two competing etiologies. And I would consider a TE for to look for a PFO. Could it be paradoxical embolism or malignancy workup in those patients?
In a patient who has two possible etiologies in ESUS, what do you say? Do you just document that they have this and this? I'm not sure which one caused it. Both are bad.
Yes, then that's when it becomes a cryptogenic stroke when you have two competing etiologies. And then, so that's why like when the way I would document in my note goes with any neurologist we want it to be documented. When you explain their mental status, instead of using one word, please explain what you mean by that. Altered mental status, unfortunately, does not tell me any information of what the patient is going through. When you say ESUS or two competing etiologies, I want to know what are those competing etiologies are. So then they would say ESUS, large vessel versus cardioembolic. It completely beats the purpose, because when you say large vessel, it means like it's a symptomatic artery. Then it's not an ESUS anymore. So that's why like we need to clearly define what is the two competing etiologies. Then that will help us to know whether this is ESUS or not. If somebody is having more than 50% stenosis, then there's not ESUS. Then you can call cryptogenic stroke with two competing etiologies.
Excellent. Do you typically get MRAs for plaque morphology? And do you do that at the same time as the initial MRI?
Yeah, so it's interesting question. It totally depends upon the institution. So we have tried black blood imaging or vessel wall imaging in our institution, but we are unsuccessful in terms of quality of the images. But 3 Tesla MRI is enough to get all those sequences. So that's why we are heavily rely on cardiac ultrasounds and CT angiograms, if needed, CT, DSA. But MRI could be useful in certain areas where if you look for intra-plaque hemorrhage, MRI would be a great sequence to look in T1 to see how does the density look inside the plaque. Yes, it's definitely helpful.
I think this is a follow-up question. Could you do it for 1 month, like mentioned in Thales, for 30% stenosis with ASA and Berlinta or sinks? I think that's in reference to this question.
So the sub-study of Thales has shown that aspirin Berlinta is beneficial, but it's for 90 days. And then, yes, I would love to give Berlinta to the patient as long as they can afford it.
So when the studies hit the real world all of a sudden.
Exactly. So that's the because we are in an area where we have a lot of underserved population. And then our goal is not to just give them the prescription, making sure the medication gets to them as well.
How much do you push in the workup of a chronic ESUS?
Yeah. So that's a great question. So one of the common concepts that we get, incidental strokes or patient had a chronic stroke, what do you do? And earlier we would brush it off saying like, because we had this notion, an aspirin a day keeps the doctor away. And then we said, no, we cannot keep aspirin. You cannot give aspirin for primary prevention because it increases the risk of bleeding. But we have sufficient evidence at this point to say silent infarct patient has highest risk of recurrent stroke within the next 30 days compared to patient without a stroke. And the same goes for chronic strokes as well. If we have a stroke in the past, that itself is a non-modifiable risk factor to have another stroke. So if I see a patient with a chronic stroke, so that's when this is one of the common things that I see. Patient will come in with a basal ganglia stroke, and the patient has uncontrolled hypertension. And we see the DWI, we see basal ganglia, we see uncontrolled hypertension, and we say, this is small vessel etiology, I'm going to treat them, close the chapter. But if you see the flash sequence, they have multiple embolic stroke, which is not explained by your small vessel territory. And we know hypertension can cause large vessel atherosclerosis. Uncontrolled hypertension can cause left atrial remodeling. The same risk factors can make you have a stroke from multiple different etiologies. So that's why, like, when I see chronic embolic stroke, then I would like to do the workup to see. I may not empirically start them on anticoagulation at this point, but I would definitely work them up.
It's always an interesting consult to get in the hospital. How helpful are TCDs in non-stenotic carotid disease?
Yeah, so of all the studies that we have, TCD has the most strong evidence. So depending upon the imaging modalities used, you can look for the fibrous cap integrity in cardiac ultrasound. You can look for a carotid plaque, intraplaque hemorrhage in MRI. But the most sensitive one is TCD, because if you have one embolic hit during the monitoring, that has the highest risk of recurrence. The TCD is extremely useful in these patients. But again, going back to how generalizable that is, because not every institution has transcranial Doppler availability. But if you have TCD, please jump on it right away.
How helpful is D-dimer in predicting malignancy-related strokes?
Yeah, so that tells us that if you have high D-dimer, yes, it makes you suspicious, but doesn't mean like everybody with a high D-dimer, because you're also dealing with an acute thrombotic situation.
Mm-hmm.
We can, if you have a suspicion, it could be secondary malignancy, and if you have a D-dimer, that could be helpful. But we cannot just go just with a D-dimer and then work the other way around.
Would you treat, if you have two competing etiologies, do you try to do treatment for both?
Yes.
Okay. And
it also goes with, we recently had a patient who came in with tandem occlusion, left IC and M1. They did the thrombectomy. Patient keeps re-occluding the left proximal carotid because it's 90% nasty stenosis. And then they had to do a stenting right after thrombectomy. And then EMS tells us on route to the hospital, patient also, they had an AFib on the monitor. And it is also seen in our EKG as well. Now the question is, are you going to say this is a large atherosclerotic etiology from the proximal carotid stenosis, or the patient has AFib? So you had two competing etiologies. So you would treat for both. You stent the patient and you take care of AFib with anticoagulation, depending upon the timing of the anticoagulation changes, but we would consider anticoagulation for the patient.
if you've got your ESUS patient, you've done all your very thorough, detailed workup and still don't have a clear etiology, would you ever use empiric anticoagulation in those patients?
So far, we don't have any evidence to say empiric anticoagulation, so all the 4 trials. But if you have done the thorough workup, if the patient still has ESUS, if you want to consider empiric anticoagulation, then I would see the age of the patient. If the patient is more than 75 years old, so then we have at least evidence from the recent few trials that empiric anticoagulation is beneficial in that age group.
And do you truly believe that ESUS should be in the TOAST classification, or does every stroke have a reason we just haven't found yet?
So ESUS still should be there, but we need to make sure we have right patient with the ESUS.
Yeah.
So just not do the workup and just throw them in the basket there. For example, I'm not going to complete the workup, but I'm just going to call a cryptogenic stroke and move on. And so that's why it's important for us to do the thorough workup, but still keep ESUS in the mix.
Yeah, and I agree that every stroke probably does have a reason that we just haven't found yet. And someday in the future, maybe we'll no longer have any unspecified folks, but you need a place to put them right now. Well, that was great. Thank you very much. And that's all our questions for today. That's now I basically can go to telestroke again at this point. After this talk, I'm back in the mix. It feels good. Thanks.
And thank you for the opportunity. And then Dr. Arif put so much effort in preparing this lecture as well. And then it's a fantastic thing for our residents to be involved in the series. And thank you, Dr. Weber, for this great idea.
Absolutely. Thank you so much, everyone, for joining us today. We are so excited to have you here, and please look out for our March lecture, which will be on Parkinson's. You will find this lecture on YouTube later if you wish to review. Thank you again so much for being here.